Hey guys, welcome to the last video of BRTP 05. In this video, I'm going to talk a little bit about oxygen toxicity, and then I'm also going to talk about pulse oximetry a little bit. So let's start out talking about oxygen toxicity. So oxygen toxicity is damage that happens to the lungs when the lungs are exposed to high concentrations of FiO2 for a long time, usually about 48 to 72 hours. So if the lungs are exposed to more than 50% FiO2 for longer than 48 to 72 hours, oxygen toxicity can happen. The exact way that it does happen is not really known, but it damages the lungs. And so we really want to try to keep our oxygen levels below 50% if possible, 50 or below. And the two primary factors that factor into how harmful the effects of oxygen toxicity are the amount of FiO2, how high it is, and the amount of time that the patient was exposed to that FiO2. So the next two slides just talk about what kind of happens during the process of having oxygen toxicity and the damage that happens to the lungs. You do not need to know this for the test. I'm just letting you know that right now there's already enough stuff to study for. But basically what happens is you have a high PaO2 and the partial pressure of oxygen starts to damage the capillary endothelium. And then you end up with this interstitial edema, which is kind of a swelling and engorgement of fluid in the interstitial area, which is the area between the alveoli and the lung tissue. And then you end up with this thickening of the alveolar capillary membrane. So the membrane in which oxygen passes from your lungs to the blood becomes thicker, so it's harder for the oxygen to get through. As this kind of continues, your type 1 alveolar cells, which are the ones that participate in gas exchange, start to get destroyed, and they're replaced with type 2 cells, which are the cells that grow in the interstitium, and they don't produce, participate in gas exchange. And so you damage your good cells for gas exchange, and then when they grow back, they're replaced with ones that don't really help you out too much. This can result in fluid starting to back up into the alveoli, which messes with your VQ ratio, your ventilation to perfusion ratio. You can have physiological shunting, which shunting is where you have perfusion going to the alveoli, but you just don't have air getting to them because of that alveolar flooding, because there's fluid in the alveoli, so that gas can't get through the fluid to get to the capillary membrane. And then you end up becoming hypoxic because of that. If it becomes really bad and you've been exposed to high oxygen for a long time, you can get hyaline membrane formation, which is kind of like hyaline it's kind of like a cartilage kind of. It's like what babies' bones are kind of made out of before they're born. It's like a flexible cartilage, kind of like what their soft spot is made out of up here. And so that kind of membrane starts to form in the alveolar region, and it's just hardening, and it doesn't participate in gas exchange anymore. And because you have this hardening of this hyaline membrane, you have like what they call pulmonary fibrosis, which is like a scarring. And when you have that scarring, it's harder for blood to flow through, and then you end up with pulmonary hypertension. And as this kind of starts to get worse, you are become more hypoxic. So then you may need more oxygen because you're becoming more hypoxic, and then that's making the problem even worse. And so it's kind of like this vicious cycle that can occur where you're hypoxic because of the oxygen toxicity, but if you give more oxygen, it's going to make it worse. And so we'll use other things, and we'll talk about that during ventilation, but positive pressure, kind of like how CPAP is, can help with that kind of stuff, with help with oxygenation without having a high FiO2. Another thing to note is that if this ends up happening to somebody, then it can be reversed if it doesn't go too far. So it's always good, if you have to have somebody on high oxygen for whatever reason, to try to wean them down as quick as possible, and the lung may be able to recover. Okay, so in this slide, I want to talk to you about COPD and hypoxic drive. So the normal PaO2 for a COPD patient is 60. So a normal PaO2 for a normal person is 80 to 100. So this is important because this is where 60 is where we want to keep the PaO2 for a COPD patient. We don't really want to go much higher than 60. We don't want to aim for 80. We don't want to aim for anything above 80 for sure. We want to keep it in the 60 range. So when we're doing that calculation that we learned in the first video, which is your desired FiO2 calculation, if we're doing that for a COPD patient, instead of using 80 like we did for a normal patient, we're going to use 60 for a COPD patient, okay? So we're going to aim for a PaO2 of 60 for these people. If we raise the patient's PaO2 above 70 with supplemental oxygen, it may knock out the COPD patient's hypoxic drive and cause hypoventilation. And so what that kind of means is there's a whole process to it, but basically the way your body works is you have these chemoreceptors, and the chemoreceptors, they measure the amount of carbon dioxide in your blood, and that's what tells your brain to breathe and how fast to breathe for a normal person. But because COPD patients are chronically high on CO2, that doesn't work for them anymore. They no longer can rely on that system. So they switch over to chemoreceptors that measure oxygen in the blood because their CO2 receptors are fried from having high CO2 all the time. And so the amount of oxygen tells them how much to breathe and when to breathe. If we start giving them supplemental oxygen and we give them we get their PaO2 to a normal person's PaO2, their brain the chemoreceptors tell their brain to stop breathing because they have enough oxygen. And so these patients will become drowsy and somnolent and start hypoventilating, breathing really shallow, breathing really slow. So with these patients, it's really important to keep their oxygen in that 60 PaO2 range, so around 60, okay? We don't want to go higher than that. So the best devices for these patients are low oxygen devices. So we always want to use low FiO2, low amounts of oxygen with these patients, and so with COPD patients. So COPD being emphysema and chronic bronchitis. So the O2 devices we want to give them, we want their FiO2 to be less than 30. Okay, and so if that's 1 or 2 liter nasal cannula, or if that's a Venturi at 24 to 28%, that's good, okay? So when you're taking the test and you're taking your boards, it can either nasal cannula or Venturi can be a right answer, but just look at which one is most appropriate, which one has a low amount of oxygen below 30. So if you are going to put oxygen on a patient who has COPD, and the two options are a nasal cannula at 2 liters per minute or a Venturi at 35, we're going to go with the nasal cannula. The only reason why I bring that up is because the boards love to use the Venturi mask on COPD patients. This is like their favorite device to use for them, but it has to be in the right range. It has to be less than 30%, okay, for it to be appropriate for a COPD patient. Also keep in mind that when we're thinking about oxygen devices for COPD patients, if they're going home on oxygen, we're going to go with the nasal cannula because it's easy to use at home. It doesn't use a lot of liter flow. We're not going to go with the Venturi for home use. We'll use the Venturi when they come into the hospital. And really what we're trying to do is use a FiO2 less than 30, keep their PaO2 around 60, and aim for an SpO2, which is your pulse oximetry reading, of 88 to 90. That's our goal there. So the one exception I will throw in there is during resuscitation. If a COPD patient codes and their heart stops and we have to do chest compressions and bag the patient to resuscitate them, we're going to use 100% oxygen at that point in time because the patient is already dead basically at that point, and we're trying to revive them and get as much oxygen to the brain as we can. So now let's start talking about pulse oximetry. So pulse oximetry is a little device that has a probe with diodes on it that go on your finger or your toe or your ear or even your forehead. and it has a photodetector on one side, and it has two lights on the other side, a red light and an infrared light. And it shines through your finger, and it measures the amount of light that comes through the other side. And when you're looking at your display on your pulse ox, it should kind of look like this, which would be like pulsatile. So this will be like your artery. Nice, every heartbeat should be a nice kind of mountain like that. So it uses a probe. It transmits the two wavelengths of light, the red and the infrared, right through your finger to the diode on the other side of the finger. So light goes in one side, comes out the other side, and it gets absorbed here into a photodetector, and then that measures how much light made it through. It can be used on your fingers, toes, earlobes. As the red light passes through your capillary bed, some is absorbed by deoxygenated blood before reaching the photodetector. So the red light is absorbed by deoxygenated blood, and then oxygen saturation is measured by comparing the amount of red light absorbed by deoxygenated blood in the hemoglobin to the amount of infrared light absorbed by oxygenated blood. So the red light gets absorbed by deoxygenated, the infrared gets absorbed by oxygenated, and this little photodetector at the bottom here compares the two, and it tells us how much saturation is going on in your hemoglobin. So pulse oximetry, it provides an indirect measurement of your oxygen saturation of the hemoglobin in your blood. What's important to point out here is that this device is not measuring your hemoglobin. It doesn't tell you what your hemoglobin is. You need to have blood draw for that. It tells you how saturated the hemoglobin is with oxygen. Okay, so there's a difference there. It doesn't tell you the amount of hemoglobin. It tells you the amount of oxygen saturation on the hemoglobin. Okay. A pulse oximeter is an instrument that is non-invasive, and it measures your oxyhemoglobin saturation, so the amount of oxygen that's bound to hemoglobin in the arterial blood, and your pulse rate. So it tells you your heart rate and your oxygen saturation in both. The great thing about this is it being non-invasive. So the best way to tell somebody's oxygenation is through an ABG, but that's invasive, and you have to poke the person in the artery, draw blood, run it, and all that. This, you can just slap on somebody's finger, and in 30 seconds, you'll know what their oxygen saturation is. It's not quite as accurate, but it's a lot more handy for sure. Generally, your pulse oximetry is accurate for oxygen saturations higher than 80%. And that's kind of important to note as well, that if your saturation is reading lower than 80%, it's probably not accurate. You don't really know what's going on at that point. So if you have a saturation of 70%, you don't really know. It could be 70, it could be 40. We don't know at that point. So it's really only accurate up to 80% saturation. So your pulse oximetry, it's a great way to indirectly measure your PaO2 without having to poke somebody with a needle. Your minimum acceptable value generally is going to be 90, and you want most patients to be above 90%, with exception being COPD patients where we're okay with 88 to 90 on them. So oxygen saturations less than 90 would increase would warn an increase in delivery of oxygen. So you may want to go ahead and call your doctor at that point in time and say, okay, this person, saturation is below 90. We need to go ahead and start oxygen therapy and get the order in there and get them on something. So here are just some different definitions of different types of saturations and oxygens that we can measure. So the first one is the SaO2. This is the amount of oxygen bound to hemoglobin. This one can only be got from an ABG. So you have to draw an ABG to get your SaO2. So this is a blood draw measurement, okay, of the amount of oxygen bound to your hemoglobin. Your SpO2 is what's measured by your pulse ox, okay? And so this is the percent of oxygen that is fully saturated in your arterial through the capillary bed on your finger, ear, toe, whatever. And then your PaO2 is the amount of oxygen dissolved in your blood plasma. And this one is also a blood draw from an ABG. So on this one, you'd have to draw blood as well. So these two are invasive. This one is just done on your pulse ox. If a patient has a normal pH and temperature, so they're not super acidic or running a fever, Your O2 saturations kind of correlate to a certain amount difference between your saturation and your PaO2. And so what we usually point out is that a saturation of 90 is a PaO2 of 60. And usually if they ask any kind of questions on the boards, that's the question that they're going to ask. That's because 90 is our minimum acceptable SAO or SpO2 is 90. And even though on a normal adult, 80 to 100 on the PaO2 is normal, 60 is our minimum acceptable. So we want them to at least have saturation of 90, which will give us a PaO2 of about 60. And this is just a curve that kind of shows how that works. If you look up here, it goes to 90. So just a little chart. Your normal SpO2 is, for a normal healthy adult, is about like 98, 99. Mine usually runs around like 96, 97. But what's acceptable for a normal person is anything above 95. What's acceptable for a COPD patient is 88 to about 90 or so. Acceptable in a sick patient is 90 and above. In a really sick patient, you may have SpO2 in the 80s, 85, 86, 87, something like that. So an indication for pulse oximetry, we're going to use this to assess the response of your therapeutic intervention, what you may need to do. So we'll use pulse ox to see, like, do they need oxygen therapy? Can they be weaned from their oxygen therapy? Do we need to go up, down on their liter flow or whatever? It'll tell us if they're kind of ready to wean from mechanical ventilation if they're on the vent. It can help us during sleep studies, apnea sleep studies. So if we think a patient that has obstructive sleep apnea at night, we don't know for sure, you can actually do an apnea study and put a pulse oximetry on them at night and see if the pulse ox drops throughout the night, and that'll kind of tell you if they're going apneic or if something else is going on. And then we also use it during cardiopulmonary stress test studies. And so we'll talk more about that this summer when we do that class. And then another good thing about pulse oximetry, it can help you determine if your ABG that you drew is actually an ABG. Sometimes when you go to draw an ABG, you don't hit an artery. You end up hitting a vein and you get venous blood, or it mixes together because you hit an artery, then you hit a vein, or vice versa. And so you may have venous blood mixed in with your sample and it gives you an erroneous reading. And so comparing your SpO2 to your SaO2 on your blood gas can kind of tell you if you're in the ballpark. So if you drew a blood gas and it's saying your SaO2 is 70 and you look up at the monitor and the SpO2 on the patient is 95, then you know something's not right. There's something wrong with that ABG. You need to draw another one. So there's a lot of different factors that will affect how accurate your SpO2 is or your pulse oximetry. The first one being external bright light. So if a patient is sitting by a window and a bright light is shining through the diode, it's going to mess with the red and the infrared light, and it may not give you a good reading. Another one is if patients have a weak or absent peripheral pulses, or they have low perfusion, because we read the SpO2 on the fingers and the toes and on the ear, these are the least perfused areas. So if the person has low blood pressure or they're on vasopressor drugs or something like that, they may not get a good reading. And some other things that could cause low perfusion would be like hypovolemia, so low blood volume, low blood pressure, low temperature, being on certain medications. Usually the earlobe is less affected. So if you're getting a bad reading on the finger or you're getting a bad reading on the toe, you may want to go to the ear, or we even have forehead probes we can use. Motion artifact is another thing. So if the patient's moving around when they're talking a bunch, the diode is kind of coming off their finger as they're talking, and it's going to give you a wonky reading. And this is probably the number one thing that happens because patients are moving their hands around because this thing is attached to your hand. You got to drink, you got to do other things. And so that can cause an erroneous reading. Having artificial or painted nails, that's going to block the light going through. And so that's not going to work. You may need to go to a toe or an ear if the toes are painted as well. Dark skin pigmentation can affect it as well, the transmission of light. injection of radiographic dye. So if somebody went to CT and they had some dye injected, it may mess with your results since you have dye floating around in your blood. And then there's some things that can stick to your hemoglobin that will give you a weird reading. And so the first one we'll talk about is methemoglobin. Methemoglobin is oxidized hemoglobin. So you have iron in your blood, iron oxidizes and rust, and that's basically what happens is there's a oxidization of the iron in your hemoglobin, and it kind of turns your blood like a muddy kind of rusty color. And what this will do is it will just make your saturation always read like around 85%. No matter if it's higher or lower than that, it's going to read around 85. So it could be falsely high or falsely low. We don't really know. And what usually causes methemoglobin are certain drugs, like lidocaine is one of them, but there are a lot of different drugs that can cause you to have methemoglobin. Carboxyhemoglobin is probably more common. This is when somebody has carbon monoxide poisoning. So this would be a house fire, gas leak, somebody running their car in their garage and inhaling too much exhaust. The thing with carbon monoxide is that it really binds to hemoglobin. It has 250 times the affinity of oxygen. So it's 250 times more likely to bind to hemoglobin and hold on than oxygen is. So it's kind of hard to get it out of your system, and it overcompetes the oxygen in your system. And so it absorbs and it reflects through the pulse ox the exact same as oxyhemoglobin, which is normal hemoglobin that's saturated with oxygen. So it will tell you that the person is saturating fine when they're not really. I mean, they are saturated. Their hemoglobin is saturated with carboxyhemoglobin from the CO. And so the pulse ox may be saying 100% on it, but 50% of that is carboxyhemoglobin. So technically their SpO2 is only 50%. They're only 50% saturated. So you can't really tell with the pulse ox what's going on when it comes to carbon monoxide. With this, you'd have to get a different test that's called a co-ox or a hemoximeter, which will tell you how much carboxyhemoglobin you have in the blood. So carboxyhemoglobin, normal people have less than 5%. Smokers have about 9% or less. If somebody's getting carbon monoxide poisoning, around 15 to 25%, they'll start to get like a headache and tired. If they have above 30%, they get dizzy, confused, they can faint. If it's above 50%, it can cause unconsciousness and death. The treatment for it is as much oxygen as you can give. So if you remember when we talked about the non-rebreather mask, this is where you would use that. So when the patient comes in, you suspect carboxyhemoglobin, their oxygen saturation on the pulse ox is probably going to read 100% or 90, 95, 98, 99, something like that. But it's abnormally high. It's not giving you the correct reading. The idea is to get them on as much oxygen as you possibly can to try to knock off some of that CO and replace it with oxygen. And the quickest, easiest way to do that is a non-rebreather mask. So we'll slap that non-rebreather mask on them and we'll decide what we need to do at that point in time. Do we need to intubate them? Do we need to put them on high flow nasal cannula? That's your best first action. When you're checking the accuracy of your pulse oximetry, you always want to compare the pulse rate that you're getting from your probe on your pulse ox to the actual pulse rate, either taken by literally getting their pulse on the radial artery with your fingers or looking at a ECG up on the monitor. You need to compare the two, because if your heart rate is different on your pulse ox than it really is in real life, it's not accurate. You cannot rely on that reading. So if your pulse ox says the heart rate is 75, but the EKG or the pulse that you take is in the 90s, something ain't right. And so your pulse ox is not accurate and you cannot use that. So compare your ABG saturation to the displayed saturation on your pulse ox. So if you get an ABG and your SaO2 is 95, and then you look at your pulse ox and it's reading 85, then you know your pulse ox is not reading correctly. You need to move it to somewhere else. It's not picking up correctly. So you can kind of compare the SaO2, the SpO2 to kind of see if one is correct. And then also compare what your visual assessment of the patient is to the pulse ox. So if you look at a patient, it says they're satting, their saturation is like 98%, but they are breathing heavy and they have visible cyanosis, you know that's not correct. So don't go by that measurement. And then vice versa, if the patient looks completely fine, is up, talking, not short of breath at all, and it's saying that they're only satting 80%, obviously it's not picking up right, okay? So always use that physical assessment to compare to see if you think it's reading okay. When you set up a pulse ox probe on somebody, make sure your diodes match up. So like in this one, your fingernail would go here, and this little diode will go underneath of the finger and match up to this side when you fold it over. So you need the little diodes that are located like here and here to match up when you fold it across right there. So make sure that you change your pulse ox sites regularly. So nobody wants to have this thing wrapped around their same finger for a week straight. Make sure you rotate fingers and all that kind of stuff. You can use fingers, toes, earlobes. Try to use the non-dominant hand. So if somebody's right-handed, try not to put it on the right hand because they're going to be using that hand a lot and it's just going to be annoying for them and it's not going to read very accurately because they're going to be moving around so much. On children, you can use the hand, the wrist, or the foot. Like you can see on this little neonate here, it's wrapped around their actual foot. There are forehead probes, but you cannot use a normal finger probe on somebody's forehead like this guy has here. There's a special one that looks like this that comes with the band that goes on the forehead. So make sure that if you're going to use a forehead probe, that you actually put it on the forehead and only use it on the forehead, and make sure that if you're going to put one on the forehead, it's the right probe. And then looking at accuracy, the easiest way to kind of tell if you're accurate is looking at what they call the pleth. So if you look down here at the bottom, these two wavelengths right here, this one on this side is a normal wavelength. You want to see every one of these. This is a pulsatile wavelength, and every one of these is a heartbeat. And you want them to be all equal and equally spaced apart like this. That's telling you that they're getting a good reading. If you have one that looks kind of weird, like this one right here, where it's kind of up, down, all around, spaced differently, that's telling you that they're not getting a very good connection. You may want to try a different pulse site. You can't really trust the reading on this one, the SpO2. And that's it, guys. So that's all of BRTP 05. What I will say is we'll cover kind of the concept stuff in Zoom when we talk about doing like the magic box and the air entrainment stuff and the inspiratory flow stuff. That's probably the only, that and figuring out people's FiO2s with that formula and then figuring out what device is for them. That's probably the hardest part about this lab. The rest is just memorization, but there's so much memorization. You need to know about all the devices, if they're high flow, low flow, what their liter flow range is and what their FiO2 range is. If you look in your lab book, there is a lot of information sheets in here. You need to read all of those on your own. They're just going to kind of reaffirm the things that we went over here in lecture. But on page 10, there's a breakdown of the more important devices that you're going to be tested over, and it gives you a list of your liter flows and your oxygen percentage. You do need to pretty much know everything on that page. So make sure you read through your information sheets on your own. And we will get together on Thursday for Zoom, and practice some problems with the magic box and anticipatory flow and answer any questions that you guys have. So that is it. That's all I have for you guys. Make sure you come to Zoom with questions. This is kind of one of the more difficult ones, I think, to kind of teach online. So please come with any kind of questions. A lot of this, when I would lecture, would come from feedback. So when the students would ask questions, then we'd go into different topics. And when we record videos, we can't really do that. So make sure you're coming with whatever questions you have. And if the magic box stuff doesn't make sense to you after watching the videos, that's okay. We're going to practice it again in Zoom. Okay. So thanks for watching, and I'll see you all in Zoom.